Hi everybody, we're back for Unit 4B, the anxiety-related disorders. I've posted your lesson objectives. We are in Townsend, chapters 27, 28, 29. Very good material for you to read. They have some very good tables and charts and resources in your textbook, and so I encourage you to use that resource. I'm not going to repeat the lesson objectives. You can read them. What I will tell you is that anxiety is something that you will encounter in your nursing career no matter where you work. Anxiety is very common in people who are hospitalized. It can be related to the hospitalization itself. It can be related to a diagnosis. It can be related to treatment. And sometimes it can be related to phobias of needles, claustrophobia, where people can't handle an MRI machine. And so it's very helpful to you to have a working knowledge of how we deal with anxiety as nurses. So the disorders that we're going to cover: generalized anxiety disorder, obsessive compulsive disorder, panic disorder, post-traumatic stress disorder, and then some of the somatoform dissociative disorders, which honestly you are unlikely to really see in your first year of nursing, but we will cover them briefly anyway. We'll talk about alternative methods and non-pharmacological methods, but we are also going to discuss the pharmacology, which is very important in the treatment of anxiety. If you want to follow along in your textbook, I'm going to try and include the chapters and pages as often as possible. Sometimes I will reference material that's outside of your text, just to help you understand it and be able to apply it a little bit better. But for the most part, you can follow through your text for this material. It's fairly straightforward. So what anxiety is, it's an emotional response to the anticipation of danger. According to your text, the source of which is largely unknown or unrecognized. It is not the same as stress. Your book refers to a stressor as an external force which is brought to bear on a person. In other words, it's a person, place, or thing that represents a threat to your equilibrium. And anxiety can be the response that we have to that stressor. Fear is a cognitive response, and it involves the intellectual appraisal of that threatening stimulus. And anxiety is often the result of stress and fear. Okay, so anxiety is sort of a necessary thing. That's how we got out of the cave alive. It can be a very powerful motivator. Mild anxiety actually helps you retain information better. People who are a little bit cautious or afraid, have just small amounts, manageable amounts of anxiety, often do perform better. But it can also be a crippling disorder that's characterized by exaggerated reactions to relatively mild stimuli. According to your text, let's see if I can shrink some of that and make that bigger. It becomes a problem when it is out of proportion to the situation that is creating it, and or it interferes with social, occupational, or other important areas of functioning. And that's important to note, because anxiety can be very mild and a normal thing that people experience, or it can be something that characterizes them and sort of interferes with their normal daily lives. As I said, when you're working in the hospital, whether you're in psych or not, you're going to come across anxiety. It's sort of pervasive. Anxiety is considered somewhat normal in a lot of the contexts of healthcare. People are anxious because they are experiencing painful procedures. They're anxious because they don't know what to expect from a surgery or from a hospitalization. They're anxious because they're not sure how their illness or new diagnosis is going to impact their life. Sometimes they're having a developmental crisis. Sometimes the family has anxiety in regards to a patient, so it is something that you want to be familiar with. Anxiety can be acute or it can be chronic. And acute anxiety, most of us are familiar with. It's sudden onset and short duration. Test anxiety is an acute anxiety. It's triggered by an event. You get very anxious. All of a sudden, test is over. It goes away. So that's acute anxiety. Okay? And a lot of times it does look more severe, although it can run the spectrum. But that's what acute anxiety is. And it's just the way it sounds. Now, chronic anxiety is different. These are the people who are chronic worriers. They look a little bit more stable.
Now, as far as the duration, or how long it has to last, I'm going to tell you it's 3 to 6 months, and then I'm going to tell you why it is 3 to 6 and not one or the other. Your book says that generalized anxiety disorder occurs over a period of 6 months, and I believe that's the DSM-5 criteria as well, more days than not. But ATI does say that generalized anxiety disorder occurs for more than 3 months. So just be aware that those definitions exist and where they come from. But chronic anxiety looks a little more stable. They tend to be your nervous people, your worrywarts. But they're not having an acute reaction. They aren't maybe sweating or have the palpitations or the dry mouth. The chronically anxious people might be the ones who always look a little rigid and always a little edgy. So that's acute versus chronic. Okay, and now I'm going to bring in a concept about severity of anxiety that isn't listed in chapter 27 in your textbook. But it is sort of important to understand, because if you can see the signs of worsening anxiety, you'll sort of know where that person is and you'll know how to intervene. And that's the kind of thing that comes up on test questions a lot. It may not ask you what moderate anxiety looks like, but they'll describe a patient with moderate anxiety, and you'll need to know the characteristics of that in order to plan and implement appropriate nursing interventions. So we'll start with mild anxiety, or level 1. And actually, mild anxiety can be a positive thing. We have increased alertness, increased perception, you see more, you hear more, and you take in a lot more stimuli. You have increased awareness of relationships and meanings, and that enhances your ability to problem solve. And my best sort of example of this is you're a little bit anxious when you take a test, but it sort of sharpens all your senses and you're able to read that question and be a little more alert. As long as you're still in that level 1 mild anxiety, you problem solve. Or you're faced with a challenge, maybe it's, you're driving on a curvy road in the rain, you get a little more alert, it enhances your ability to drive. So that's mild anxiety, or level 1. Now when we get to level 2 anxiety, or moderate anxiety, this is where the person's problem-solving ability tends to decline. And that patient might need some assistance to see a solution to their problems. And at this point, the individual becomes less alert, and they focus on the stressor to the exclusion of other things in the environment. Okay, so that is your moderate anxiety, and what this might look like, signs and symptoms might look like, pacing, patient verbalizes their stress or their feelings of anxiety. At this point, you might get some physical symptoms, but you'll get also restlessness and nervousness. And so those are some things that you want to watch out for in moderate anxiety. Now, if you are in the psychiatric setting and you've got a patient who, in addition to their bipolar disorder or schizophrenia or borderline personality or whatever it is they are in there for, starts to exhibit moderate anxiety, this is where you want to start to de-escalate. And you want to intervene at this level rather than waiting for level 3 or 4, because a person who could become aggressive, maybe they're paranoid or maybe they're so anxious that they become aggressive, as they experience higher levels of anxiety, are a little bit more difficult to redirect. Okay, we move up to level 3, which is severe anxiety, and this is where it's really hard to redirect people because they're starting to escalate, and that nervousness sort of takes over, and any explanation you can give them gets a little bit lost in the translation. Their focus becomes extremely narrow. They're on one tiny detail or many irrelevant details. They can be very scattered. It can be hard to communicate with these folks because they're not getting out coherent sentences. Their intellectual processes are decreased. They have a lack of ability or motivation to perform. Oh, wait, sorry, this should be purposelessness, not purposeless news. So they kind of feel like they're just, they can't do anything. They feel a little bit paralyzed. There's a sense of impending doom, and those physical symptoms that start out with a little, maybe an increased heart rate and a little bit of sweating and maybe GI symptoms like nausea, they really increase to the point where the person is very physically and emotionally uncomfortable. You might see some autonomic nervous behavior. Again, the dry mouth, the sweaty palms, rapid heart rate or palpitations. They might feel dizzy. And so this person is starting to decompensate. And it's going to become extremely hard to sort of refocus them. They will have poor recall as well. This is like really at the point where their thoughts are getting distorted. And so when you communicate with this person, you need to have clear, simple statements. Any kind of explanation or teaching will just go out the window at that point. So that is level 3. When we get to the opposite end of the spectrum, the most severe anxiety is when we get to panic state. And in this state, it's going to be very, very difficult to refocus your patient or get them to sort of calm down. And in fact, you may need some medication. You may need something short-acting to get them sort of in a state where they're not so wound up. In the panic state, you have this complete loss of control. There's a disruption of the ability to perceive. They are not processing stimuli that come in. There's a disintegration of the personalities. People will act very psychotic. They will not act like themselves sometimes because the rational self is no longer functioning. They will have difficulty verbalizing. They may be unable to focus on what's going on around them. They might be shouting. They might be pacing. They might be sort of pushing everyone away. And at this point, patients who are prone to physical aggression may become aggressive or violent. And this is why you want to know what the levels of anxiety are, because when you're at level 1, everything's good. That's a person who's ready to learn and ready to work with you. When you're at level 2, you still have a chance to bring that person back. When you get to 3 and 4, you're looking at a person who is very difficult to redirect. And at this point, you need to reassure the patient that they're safe, first of all. You need to reassure them that they're not going to die because they may have that fear. You may have to medicate, and you have to communicate in very short, simple, clear statements. Sit here. You can't really use too many words. These people cannot process what they're hearing. So be aware of the different levels of anxiety and how the nurse might approach those. Along those lines, we're going to talk about a panic attack. And a panic attack is something that lasts typically about 15 to 30 minutes. They can last longer. They can be a little bit shorter. But you might see panic attacks working in the emergency room because many of the manifestations of them are similar to your cardiac disorders. The most prominent is palpitations, a pounding heart or accelerated heart rate. Usually these people, if you put them on the monitor, will look like they have sinus tachy. They don't go into SVT or any other abnormal rhythm. It's a sinus tachycardia. You have sweating. You have trembling or shaking. And this is all in your book, but I'm just kind of summarizing it for you. The shortness of breath. And see what I mean about the cardiac. They get chest pain and pressure. So a lot of times these people think that they're having a heart attack. They think they're going to die. They come to the emergency room and find out, no, their cardiac enzymes are normal and their strip looks okay. They could have nausea. A lot of times they'll have GI distress or vomiting. They might feel dizzy. Again, this all mimics your cardiac symptoms. This is why historically anxiety was considered like soldier's heart, because it was connected to stress and post-traumatic stress disorder, but it mostly manifested. It looked like heart disease. You might get chills, or you might get like hot flashes. And then you get you might get numbness or tingling, and that's a lot of times from the hyperventilation. But again, that can look really abnormal. It can look like a cardiac, it can look just like a heart attack. Then there's the fear. And remember, fear is that cognitive appraisal. Anxiety is that emotional reaction that causes all these physical changes and all these differences in perception. The fear is what you say to yourself. Fear of dying, oh my God, I think I'm going to die, and fear of losing control or going crazy. And so that's what a panic attack looks like. Now, just to make you aware, there are lots of things that can look like anxiety that are really caused by medical conditions or substances that a person is using. Number one on this list, I would put caffeine. So when somebody comes to you and they've got symptoms of anxiety, you might want to ask them, what's your typical caffeine use? And be aware that caffeine is in many products. Maybe they're drinking green tea because they think that it's good for their health. Green tea has caffeine, coffee, cola drinks. So somebody drinks a 2-liter bottle of Diet Coke every day and comes to you with symptoms of anxiety, you might tell them you need to start looking at caffeine-free. Red Bull. And most people kind of know that if they feel jumpy, they're going to stop, but some people might be unaware of the amount of caffeine that's in their accumulated intake. Amphetamines are stimulants, both the illicit kind and the kind that are used to control attention deficit disorders, can cause anxiety. Cocaine, obviously. The hallucinogens, because they cause such irrational thoughts, can cause anxiety. Bronchodilators, for example, people who go on neb treatments for albuterol might get a little bit of nervousness. And if they're already mildly anxious, that can precipitate sort of a little more anxiety in them. Corticosteroids are notorious for causing emotional disturbances, including anxiety. And then there are medical conditions. Anything that's cardiovascular. If your heart feels like it's racing, maybe your heart really is racing. Maybe you have an arrhythmia. You're an AFib or SVT. So we need to rule out medical causes of these symptoms as well as psychological causes. Hyperthyroidism causes a fast heart rate and nervousness. Hypoglycemia, you guys remember diabetes. I told you, it feels like you're going to die. You get a total fight or flight reaction. Anything that causes that adrenaline release, including adrenal tumors like pheochromocytoma. Don't write that down. It's not that important. Hypoxia is a major cause of apprehension and anxiety. It's your brain's way of saying, help me, I've got to get some air. And seizures and brain tumors and brain infections caused by encephalitis can also cause signs and symptoms of anxiety. So those are some things you want to be aware of, and when you're assessing a patient who presents with symptoms of anxiety, you maybe want to find out if they have any of these other conditions. Now that we've talked about what anxiety is as an emotional state, we're ready to talk about the different disorders that are related to anxiety. Now, I realize that in your book they launch into a discussion of panic disorder first, and then they go into generalized anxiety disorder. I like to go from general to specific because I think it helps you build a better concept base. So we're going to start with general anxiety disorder, which is a chronic, unrealistic, and excessive anxiety and worry. Now, I'm aware that your book says, and they reference the DSM-5, which is more technically correct, that it is worry that lasts 6 months, more days than not. ATI materials have a different time frame. They say more than 3 months. And in actual practice, if somebody is seeking help after 3 months of severe anxiety, a doctor may diagnose them with general anxiety disorder, even though, according to the DSM-5, it's not technically correct. But just know that if you're taking a test for ATI, they may say 3 months, but the DSM-5 does say 6 months before you can call it a disorder. Another feature of this disorder is that you can't attribute the mental state to any organic cause.
So somebody who's drinking a lot of Red Bull or who takes medications that are stimulants, somebody who has a medical condition like cardiovascular disease where they get AFib or SVT, sorry, not DVT, SVT, where they get palpitations that cause them to feel like they're anxious, do not suffer from general anxiety disorder. If we're trying to address the question of what makes anxiety a mental disorder as opposed to just a behavioral or emotional state that most of us experience, it's a matter of degree, and it's a matter of how well that person functions and how much discomfort they're in. Somebody who's made extremely uncomfortable by their symptoms, they have a lot of physical symptoms, muscle tension, pounding heart rate, nausea, shakiness. Somebody whose symptoms are that severe that they're causing discomfort is likely to seek help or is likely to be referred for help. Somebody who manages their symptoms well and functions generally is not diagnosed with generalized anxiety disorder if they have good coping skills. Some of the features, behavioral features of generalized anxiety disorder is people can procrastinate. They may have trouble sleeping, they may have trouble eating, they have poor decision making, they seek reassurance from others constantly. So some of those features are characteristics. You probably know people who suffer from some generalized anxiety disorder. Children can suffer from generalized anxiety disorder. The onset can be in childhood, usually around school age, and you'll see different types of anxiety manifest then. Separation anxiety, school anxiety, that are a little different from generalized anxiety disorder. But the pattern of generalized anxiety can begin in childhood, more likely to begin in the teens and 20s, and it can become a very persistent pattern throughout a lifetime. It does tend to be chronic with remissions and exacerbations. And moving the discussion to panic disorder as opposed to a generalized anxiety disorder, it's really more of a matter of degree. But panic disorder is characterized by recurrent panic attacks, usually more than 4, the onset of which is unpredictable and manifested by intense apprehension, fear, or terror, associated with feelings of impending doom and accompanied by intense physical discomfort. Additionally, when a person has panic disorder, they anticipate more attacks, and this causes them considerable anxiety. It's literally fear of fear itself at that point. They're afraid that they're going to have another panic attack in a place where they're afraid to lose control, maybe when they're driving, maybe when they're out in public. And so this is why agoraphobia often accompanies these disorders. Now, typically, panic attacks only last between 15 and 30 minutes. They're short-lived, but they're so profoundly disturbing that people do fear having another one. Now, again, we're talking about panic attacks. I know this is sort of a review, but let's talk about it anyway. 4 or more of these symptoms will be present during a panic attack for it to qualify. You'll have palpitations, shortness of breath, choking or smothering sensation, chest pain or discomfort, sometimes pressure, nausea, and then you have some vasomotor changes. You'll get chills and pallor and flushing. And sometimes you'll get some sweating, and sometimes you'll get dry mouth. You get feelings of depersonalization, and this is a feeling of unreality, or things aren't really happening to me. It can feel like time is very distorted. You get the fear of death or the fear of insanity, if you think you're having a heart attack or you think you're just going crazy. And so the patient then who has experienced this gets very afraid of the next panic attack, and that is what causes them to seek help. And we'll talk about some of the treatment modalities and some of the psychopharmacology that is used in the treatment of this disorder in a different part of the presentation. However, what you should know is that there are some theories about what predisposes people to having a panic disorder. There's psychodynamic theory your book talks about, and that's sort of a weakness of the ego in dealing with the id and the superego. Very interesting in a Freudian sense, but probably not as accessible to you for a nursing practice. Cognitive theory, which is a little more important because most people who have panic disorder or generalized anxiety disorder are referred for cognitive behavioral therapy. And what cognitive theory talks about very generally is that what causes your anxiety or your panic is a false cognitive appraisal, distorted thinking. And so cognitive therapy aims to change those thought patterns by replacing them with healthier thought patterns. So anybody who has negative self-talk or who appraises a fear unrealistically, those people are likely to end up in generalized anxiety disorder, and we correct that by helping them with positive self-talk and helping them put their fears and anxiety into perspective. Then there are the biological aspects, and this is also important for you because it helps you understand why we use some of the medications that we use and why certain things can run in families. It's important to take a family history whenever you're dealing with a mental disorder because many of them have some familial basis. So the chemicals that we can see as implicated in anxiety disorder and panic disorder, the neurotransmitters that are generally at fault, we have serotonin, we have norepinephrine, and we have gamma aminobutyric acid, or GABA, thought to be causative of anxiety disorders. And so that's why we see things like SSRIs and SNRIs. These are selective serotonin reuptake inhibitors or selective norepinephrine uptake inhibitors. And don't get too worried because that's a whole separate piece of this presentation, and we will go into those in more detail. Just understand that the different theories sort of try to address the causes at the root so that we can help this person function a little bit better. We're turning our discussion now to the phobias. We are on Townsend, pages 533 to 536. There's a nice table on page 535 if you want to follow along with the specific phobias. We're not going to cover them all. We're just going to do a general discussion. A phobia, as we know, is an excessive and specific fear. It's unreasonable in the context of the threat that the stimulus really presents. And people know what a phobia is. About 25% of the population has a fear of something. In the healthcare environment, you're likely to encounter people who have fear of needles. When they're covered in tattoos and have multiple piercings, it doesn't seem to make much sense. But you will have people who are very, very afraid of certain things. Claustrophobia a lot of times impacts us because these are people who can't handle the MRI machine. They don't want to go up the elevator in a wheelchair. It can be a little bit difficult to work with. Most phobias do not impact day-to-day functioning because people can avoid the object of their stimulus. If you're afraid of public speaking and you never have a job in public speaking, you're not going to have much of an issue. However, if you're afraid of leaving your house, as in agoraphobia, agoraphobia literally is fear of the marketplace, but we're going to call it fear of open spaces. Really, these are people who are afraid to leave their own homes. This is very often begins with panic disorder. And what happens is the person isn't so much afraid of the open space as they are afraid of having a panic attack in the open space. So it's literally fear of fear itself. They might be afraid to go anywhere alone where they might lose control in that situation because panic disorder, again, is very scary and the person has no control at that point. They may be afraid to drive a car. So agoraphobia can be very disruptive. It impacts relationships. The person, the caregiver in this situation, a lot of times feels a role strain because not only are they dealing with this individual that they love who is very, very dependent on them, but now they're usually the only wage earner. Unless the individual with the agoraphobia can work from home, they really have a hard time functioning in the workplace. Sometimes you'll find people whose agoraphobia is specific and they can work in a workplace as long as somebody else takes them there and they don't have to go elsewhere. The office and the house are safe, but other places are not. But you can have a person who can't handle the grocery store, who can't handle shopping at the mall, who can't go to a wedding, their own sister's wedding, or they can't go to a funeral. And so this person has impaired social and occupational functioning. If it is related to a panic disorder, we might want to get this person help before they become severely agoraphobic. And we'll talk about some of the ways that we do that later. The other disorder that can be very disruptive to everyday functioning is social anxiety disorder or social phobia. And social anxiety disorder has many variants. It can be as mild as fear of public speaking, where the person just is afraid of embarrassing themselves or drawing negative attention to themselves in that situation. Or it can be a little more global, where they're afraid of going to work functions. They are petrified of various social situations in which they might embarrass themselves or draw negative attention to themselves. Social anxiety disorder, as you can imagine, can also be very disruptive. Life is full of social situations, and you don't get through it without sometimes embarrassing yourself. That's just the way it goes. So a person who is very phobic of those situations is in need of help. And there are some pharmacological agents as well as the more cognitive behavioral psychotherapy type treatment modalities, paroxetine or Paxil, as we'll find when we discuss pharmacology, are indicated for social anxiety. Okay, in addition to those two phobias, we have specific phobias, and as I said on page 535, if you know enough Greek, you can make any number of phobias. People can be afraid of anything. People are afraid of heights, people are afraid of clowns, people are afraid of germs, and this can impact their day-to-day life more or less severely depending on how likely they are to encounter the stimulus. So there are a couple of ways that we deal with specific phobias. One of them is implosion therapy, which we'll talk about more with the treatment modalities. Implosion therapy is also called flooding. We expose that person to a lot of the stimulus that makes them afraid. And of course, this has to be done in a supportive atmosphere with a trusting therapeutic relationship. You can't just take a person who's afraid of swimming in a pool and throw them in it and tell them to swim. That's not implosion therapy. Implosion therapy may include that action eventually, but in the context of a trusting therapeutic relationship. Then there is what we call systematic desensitization, and again, we'll cover this. Again, you'll hear it one more time, and you'll see it again in your textbook. Systematic desensitization is exposure to that stimulus in stages. Maybe now we talk about it, and now I show you a picture of it. You're afraid of spiders. We're gonna talk about spiders, and we're gonna try and diffuse your anxiety. Use some techniques to de-escalate your anxiety. Then we're gonna look at pictures. Then we're gonna stand in a room where there's a terrarium with a spider in it, far, far off in the corner. Then we'll take baby steps to get closer. That's systematic desensitization, and that works for most of your specific phobias. Now, your book mentions different theories that explain what predisposes people to phobias. You can read about those. Psychoanalytic talks about how the phobia really represents the parent of the opposite gender. It's interesting, but probably not too applicable to your practice as a nurse. We have cognitive theories and learning theories. And learning theories work on that conditioned response, that behaviorism. And cognitive theories work on the distorted thought patterns that cause the phobias. And that's where we get our implosion therapy and our flooding therapy from. Those are mostly their behavioral techniques, and they usually incorporate some cognitive therapy as well. Now, one thing that you can remember about phobias, they generally begin in childhood. Children, as their imaginations grow, it's a developmental stage. Right around the age of 3, between 3 and 5, that preschool time, they become afraid of various things, and they'll develop like a mini phobia that goes away. Sometimes those phobias persist into adulthood, and sometimes they disappear or go underground and then return the next time that person encounters a stimulus. So those are developmental considerations with phobias. We're launching into a discussion of obsessive compulsive disorder, and if you want to follow along in your text, we're in Townsend, pages 538 to 541. We need to make a distinction here between obsessive compulsive disorder, which is a manifestation of anxiety, which is what we're talking about now, and the common perception of what OCD is. People joke about having OCD, they joke about other people having OCD, and what they really mean is that that person is perfectionistic, or that they're attentive to detail excessively, or they have maybe sort of a preoccupation with cleanliness or order, or, they're very fussy people. That's not true OCD. That might be better described as obsessive compulsive personality disorder, which is a separate topic we'll cover next. But try to understand what obsessive compulsive disorder really is, and then you can understand how distressing it is to the patient. OCD is marked by obsessions. And obsessions are those unwanted thoughts or images or impulses that the person just can't shake, even though they understand that it's not logical or rational to think this way or feel this way or have this impulse. They are unable to talk themselves out of it, and it's not something that you can talk them out of. It's not something that you can say, well, rationally, you don't need to do this. They know that. They just have this obsession, this recurring thought that causes them severe anxiety. The anxiety they get from the obsession is what leads to the observable behavior that we know as compulsions. Compulsions are those things, the ritualistic behaviors. They can be very repetitive. These are things like hand washing, or picking at your skin, or pulling your hair, or checking things over and over and over again. The compulsion is a way to reduce anxiety that's caused by the obsession. And when we understand sort of the theories that are behind OCD, we'll understand where these obsessions arise. So for example, if you have a patient, you see a lot of hand washing, and it's not just hand washing for, frequently, but this is sort of ritualistic hand washing that happens maybe 40 times an hour, and you see that the person has chapped skin. This person has an obsession. Maybe they have a sensory image of their skin crawling or being dirty, and they just can't stop feeling dirty, 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 dirty. So they wash their hands, and they still feel dirty, and they still have anxiety. So they wash them again, and they still feel anxiety, so they wash them again. The compulsion is a maladaptive coping mechanism to deal with the obsession. So it's sort of a defense mechanism. And that's what OCD is really all about. Now, there are certain variations of OCD that your book goes into, and there are 3 off the top of my head. There are trichotillomania. That's a mouthful. There we go. And that's hair pulling. It's excessive hair pulling. And what happens in trichotillomania is it usually starts in childhood, but it's a response to stress. The person has an unwanted impulse to pull their hair. And they pull their hair and they feel sort of a release of tension until they have bald spots, which causes them distress, but they still can't stop the trichotillomania. It's sort of a motor pattern they can't get out of. So that's what trichotillomania is. Then we have hoarding disorder. So the next variation on obsessive compulsive disorder is hoarding disorder. And I know we've all seen the reality shows. As a nurse, you are less likely to see this in the hospital. People won't admit that they have hoarding disorders. They don't usually come seeking help. Where you find it is in the community. When you're a home health care nurse, or even if you work in any area where you're likely to be in someone's home, if you work for EMS, for example, you may find this almost incidentally. And it is the persistent, I'm just taking right out of your textbook here on page 538, difficulty discarding or parting with possessions, regardless of their actual value. Okay, so that, or it can be excessive acquisition, the collectors. And here's what you might find. Let's say you're on a home care visit for somebody elderly. They've just been discharged from the hospital. Maybe they fell, they went to rehab, now they're home, and you have to go and check on them. You might find people with piles of newspapers that go back to 1962, magazines, people hoard cats, dogs. That might be something where, you have a patient who comes to the hospital for whatever other reason, and they, you find that they're very anxious, and you say, well, is there anything I can help you with? Or you seem anxious. Would you like to talk about what's making you so worried? And they say, well, nobody's home to feed my cats. So maybe someone goes over there and finds 40 cats, and there is cat urine and cat feces all over the floor. That's an example of hoarding disorder. Sometimes people with hoarding disorder will actually hoard food, and ignoring the expiration dates, they never throw anything away. The can is bulging with botulism, and they come in with food poisoning. And so hoarding disorder typically isn't the reason that people seek help, but it can be something that they need help with. And there are various therapies that we'll discuss. The other disorder that kind of falls under this broad umbrella of the obsessive compulsive disorders is body dysmorphic disorder, and this is when the obsession is really a person's appearance. So BDD, or body dysmorphic disorder. And if you were going to categorize body dysmorphic disorder under OCD, the obsession in this case would be with some perceived or imagined flaw in the body. The big difference is most people with OCD understand their house isn't actually on fire, even though they have the image of their burning house in their head. They can't get rid of it, and they have to keep checking. The person with body dysmorphic disorder is more distorted in their thinking. They can almost be a little bit delusional. They feel like their nose is way too big or their teeth are way too crooked, and they will go to any length to hide it or have it corrected. These are people who have like repetitive plastic surgeries. They kind of get wrapped up in that. Or they can be checking their makeup in the mirror constantly and taking it off and putting it back on and taking it off and putting it back on. It may take them an hour and a half to get dressed.
because they perceive a flaw that's out of proportion with reality. So it sort of has some characteristics of OCD. They're obsessed with their appearance and they have compulsions that deal with that obsession. But at the same time, there's a little bit more distorted thinking where they perceive a flaw that other people don't notice. Now, just moving along with the theories of what predisposes people to have the obsessive compulsive disorders, anything in that family. Your book mentions these. Again, we're going to go back to psychoanalytic therapy theory with Freud. And again, maybe not as applicable to nursing practice, but interesting nonetheless. We'll talk about it. It basically says that the ego is weak, and you have these impulses by the id, and the superego wants to punish. And so somewhere in between there, you get these obsessive thought patterns and the compulsions that address the anxiety caused by them. So that's psychoanalytic theory. Learning theory. That this is a conditioned response to a stimulus that was traumatic or threatening. The problem with learning theory, according to your book, and it sort of makes sense, is that most cases of obsessive compulsive disorder or OCD are not connected to any traumatic event or any particular stimulus. They sort of occur gradually in response to maybe generally stressful conditions or anxiety. And the obsessions and compulsions aren't necessarily related to the stressful events that are occurring. So there's that. Psychosocial influences. Some forms of obsessive compulsive disorder do begin in childhood, and they can be a result of stress that the child does not have effective coping strategies for. Your book mentions a few things about mother-child relationships, abuse, neglect, and those things certainly can play a role, particularly in the hair pulling disorder, trichotillomania. That tends to start in childhood. And it usually is related to some stressful environmental conditions that the child is exposed to. Biological aspects are sort of the most interesting theory and probably the most credible contributory factor. There are neurotransmitters that are definitely altered in OCD, and you see a high incidence of other mood disorders that are related to serotonin. And so the SSRI drugs, which when we talk about treatments for the anxiety disorders, we'll talk about SSRIs, or selective serotonin receptor inhibitors, reuptake inhibitors, excuse me. But serotonin has been implicated in both OCD and other forms of anxiety disorder, and also in mood disorders, particularly depression. Genetics. OCD tends to run in families. Hoarders tend to be more common among family members. And so, there is some familial predisposition. The limbic system in the brain has been implicated. So it's kind of interesting. Probably there are a lot of people who are wired to respond to stress in this fashion as opposed to some other mental disorder. There are definitely biological aspects. Your book mentions the transactional theory, so let's talk about that for a minute, or transactional model. And all that really means is that there's more than one thing going on here. So we need to consider that there's an interplay of factors, that maybe we do have somebody with a weak ego, with internal conflict, and maybe there is some sort of conditioned response. They pulled their hair, it released the tension, and so they pull their hair again. They wash their hands and it relieved their anxiety, so they keep washing their hands. So there is that interplay of influences, that maybe you had that stressful event, and maybe you were hardwired to respond this way, as opposed to becoming depressed or bipolar. So that's a transactional model of the stress adaptation, and it's important in that when you target your interventions, you're going to look at more than one way of helping people. So that's the obsessive compulsive disorders. We're continuing our coverage of the anxiety-related disorders with a discussion of the trauma and stressor-related disorders. The most severe of which is post-traumatic stress disorder, or PTSD, and most of us have heard of it.
in connection with combat. So we'll talk about that a little bit, and we'll talk about adjustment disorder, which is a disorder that deals with stress but on a more routine variety. With post-traumatic stress disorder, we're looking at something that's really kind of outside the range of what a normal person would expect. Something like war, violent crime, that kind of traumatic event. Adjustment disorder is more something within the normal range of human experience. Divorce, death, really almost anything. Failing a class, losing a loved one. Adjustment disorders are very common. So we'll begin with some background on what PTSD is. Post-trauma response. In World War I, they called it shell shock. In World War II, they called it battle fatigue. After mass casualties, they called it accident neurosis or post-traumatic neurosis. So there were all these words for it. And in 1980, after having seen the effects of what happened to Vietnam veterans returning home, a renewed interest sort of sparked a little bit of research, and they came up with a category called post-traumatic stress disorder. And your book defines post-traumatic stress disorder as a reaction to an extreme trauma, which is likely to cause pervasive distress to almost anyone, such as natural or man-made disasters, combat, serious accidents, witnessing the violent death of others, being the victim of torture, terrorism, rape, or other crimes. For example, 9/11 would be something that could cause post-traumatic stress disorder, potentially in a lot of people. An earthquake that damaged many houses and killed a lot of people. Witnessing a drive-by shooting, things of those nature that would really be severe and unusual for most people to experience can cause post-traumatic stress disorder. Now, only about 10% of the people who have been through these experiences will develop a full-blown post-traumatic stress disorder. And so it's not a guaranteed thing that everyone will experience. Some of the signs and symptoms of post-traumatic stress disorder are listed below. You can have sort of different people will manifest different things. So you can have people who re-experience the traumatic event over and over as if they're experiencing it in the real time. On the other hand, you get people who have amnesia and can't remember what happened to them. People with a high level of alertness, people who are generally numb. People who have intrusive recollections or nightmares, they have like flashbacks, unwarranted. It's almost like those obsessions we talked about with OCD, unwanted thoughts that they can't get rid of. You can have people who are depressed who have survivor's guilt. Survivor's guilt is very common in survivors of combat who have lost other people that they were associated with. You can have survivor's guilt if, somebody who made it out of the towers in 9/11 and maybe somebody they knew didn't. Those people might feel, why did they die and I didn't? Why am I still here? Substance abuse is very, very common. People are escaping the pain that they are constantly reliving. And so alcohol abuse and right now opiate abuse among veterans is very, very high. Anger and aggression, especially without provocation, and it seems almost random and illogical, that's another hallmark of PTSD. Relationship problems, very, very characteristic. And you have whole support groups that are aimed at spouses of returning veterans from war, or people. It's very hard to be able to support somebody who has experienced a trauma and you have nothing at all to relate it to. Remember, this isn't like an adjustment disorder where you're going through a divorce and I've had a bad breakup, or you've lost a job and I failed a class. This is something that most people are never going to experience, and so if you come home from war and nobody you know can relate to this, it can be very, very difficult to get the kind of support that you need. Now, the symptoms of PTSD might begin almost immediately and persist beyond a month. They can begin within that first 3-month period. There can be a lag. It can be years after the event. For example, I'll give you an example from my own practice. We can have people who have had sexual abuse when they were young children or early adolescents who don't experience any symptoms until they go into labor and start giving birth, and then they re-experience that trauma. It can be very traumatic for the nurses as well, especially if we don't know that it's happened. But that's the kind of thing about post-traumatic stress disorder. It is very variable from individual to individual, and it can take years sometimes to manifest. Acute stress disorder is very, very similar to post-traumatic stress disorder, both in terms of the type of trauma that make it happen and the symptoms that manifest. It's the same disorder. The difference is the time limited nature of acute stress disorder. Acute stress disorder, let's say that there's a tornado that wipes out my house and kills my neighbor, and I have survivor's guilt, and I have this acute stress reaction to it. But after a month, I have resolved that trauma. I'm no longer having flashbacks or nightmares or hypervigilance or amnesia about the event. I have somehow resolved those symptoms. It's when the symptoms that last longer than a month, that's when we call it PTSD. But you can have an acute stress disorder, and this happens a lot in mass casualties and natural disasters. You'll see this. So we know that only about 10% of people that are exposed to traumatic events along the lines of combat or natural disasters will develop PTSD, and more women than men. And there are a bunch of theories that are designed to explore what those predisposing factors might be. And one of them is psychosocial theory, okay? And psychosocial theory, I don't think you need to memorize any of this. None of it is all that important, but you should know that it exists. We know that there are different variables that relate to the nature of the traumatic experience, the individual, and the recovery environment. The recovery environment is probably the most critical one, but we'll talk a little bit about all of them. The traumatic experience, depending on the severity and duration of the stressor, somebody who was at war for, if you lived in Afghanistan all your life and all you knew was war, you were more likely to get a PTSD. Exposure to death, the likelihood of recurrence, the location where the trauma was experienced. If it was experienced in a foreign country and you're not likely to return there, that's one thing. But if it happened a block from your house and you have to drive by that site, then that could be a predisposing factor for post-traumatic stress. Then there are factors related to the individual. How effectively could that individual cope with normal stressors, and then they're exposed to a trauma? Any kind of pre-existing mental illness, the age, gender, socioeconomic status, education, all of these things play into whether or not somebody's going to get a PTSD response. The most important probably is the recovery environment. And probably one of the reasons that the Vietnam vets had such a tough time and so many of them got PTSD was because the environment that they returned home to was not supportive of them. You had people who were protesting the war, and they would literally throw things at the veterans and call them murderers. And then the people who supported the war felt that the survivors were being unpatriotic if they made any negative comments about it. And so they really were between two major facets of the culture and society, neither of which supported them. So there's that. The recovery environment is really critical. That's why sometimes survivors of combat or survivors of rape have a much tougher time with recovery than people who experience, say, a natural disaster where many members of their community are affected and they can sort of bind together for support. Next we have learning theory, and learning theory is most applicable when it explains how the maladaptive behaviors like substance abuse or use of anger and aggression take hold in PTSD. And the reason that so many survivors of trauma use alcohol and drugs to self-medicate is that they do experience a reduction in symptoms for that brief period of time, and so that provides a positive reinforcement for some maladaptive coping mechanisms. Next, your book goes into cognitive theory, and cognitive theory talks about the cognitive appraisal of events and the way that you view the world after a trauma. And the thing is, probably the best aspect of cognitive therapy in relation to post-traumatic stress disorder is that it helps us understand how the person's worldview is changed following an event. Their self-concept may be changed. They may feel powerless. Their belief in the world as a benevolent place is challenged. And so these people need some help with cognitive restructuring after a trauma, to go back to ways of thinking that aren't distorted. So on page 563 of your Townsend book, you might find some really interesting information about the biological aspects of PTSD and why some people are more likely to put themselves in situations that predispose them to further trauma and therefore the maintenance of PTSD. And it's interesting. Mostly what I found interesting and what I took home from that is that opioids do a lot of things, including tranquilizing and reduction of rage and reduction of paranoia and the reduction of feelings of inadequacy in people who have experienced trauma. It's sort of a self-medication, and that explains why so many veterans choose to abuse opioids and so many other survivors of trauma. And right now, with so many people who have returned from the Middle East, Afghanistan and Iraq, and the ready supply of heroin. By the way, many of our returning soldiers became addicted to heroin in Afghanistan, where the opium fields give them ready access to it, especially if they had to deal with any of the warlords that dealt in opium trade. But it explains why those, either whether they're created endogenously with endorphins in the body when you kind of stimulate that adrenaline response, then where you get the adrenaline junkies, or when we have people who self-medicate with the opioids, and why that's such a big problem. So we'll finish up our discussion of the stress-related disorders with adjustment disorders. And adjustment disorder is really a maladaptive reaction to a known stressor, something you can readily identify, and you get significant behavioral emotional symptoms. They occur within 3 months of the stressor and last no longer than 6 months. Typical examples would be an adjustment disorder following a divorce, a death in the family, although normally that will be classified as bereavement, complicated or uncomplicated. You can have people who have adjustment disorders after failing out of school, having an amputation or mastectomy, so you might see it. It is more common in depression and can be a trigger for depression. You can have disturbances of conduct. And so that is, kind of what causes the adjustment disorder. Not everyone who is exposed to a stress or a loss will develop an adjustment disorder. Some people are just more likely, and probably it does tie in with your risk factors for a major depressive disorder. Okay, so we're going to do a brief discussion of somatoform and dissociative disorders. I'm going to try and condense Townsend chapter 29, page numbers are up in the upper right corner, in about 10 minutes or less, so wish me luck on that. Somatoform disorders are disorders where emotional and mental phenomena are manifested in physical symptoms. Factitious disorder is a little bit different because that's an intentional thing. We'll kind of talk about that. The dissociative disorders include the amnesias. They include multiple personalities. They're very, very rare. So let's try and get through it pretty quickly. Somatic symptom disorder is a disorder where people will manifest their emotional and mental stress as physical symptoms. Very often their symptoms are very vague. They can be very dramatic. They share some tendencies, these folks, with people who have histrionic personality disorder, which is next week, and a lot more fun than this. They can become addicted to drugs in their quest to relieve their symptoms. They're complaining of pain, their doctors give them pain meds, they become dependent. That leads them to drug-seeking behavior. And they may have symptoms at that point because they're withdrawing from opiates. So there's that. These people tend to be very dependent on other people. They have a preoccupation with their symptoms. They're a little bit narcissistic and self-absorbed. And they like to be the patient. They get a secondary gain from the emotional support they get from other people. Illness anxiety disorder is a little bit different. This is an unrealistic or inaccurate interpretation of physical symptoms. So these people might feel real pains and aches, but they're really benign things. But every time they feel back pain, they think it's referred pain from their kidneys. Every time they have GI symptoms, they think they have colon cancer. Every freckle they see is skin cancer. These are worry warts. They have a fear of having a serious disease. Their behavioral response is very unrealistic. It's very exaggerated. They have a tendency towards anxiety and depression, and very, very frequently they have some OCD traits. These are the people who are germophobic, and they wash their hands 48 times a day, and every time they sneeze or cough, they're convinced they're dying.
Conversion disorder is a loss of or change in body function that can't be explained by anything medical. And all of these people, you will give them every diagnostic test in the book and never come up with a thing. But conversion disorder tends to be very, very dramatic when it happens. It's very uncommon. But the classic conversion symptoms are neurological. Freud found a cohort of young women who would experience hysterical blindness. It was a sudden loss of vision following when they witnessed a sexual event or when they experienced their first sexual experience. Sometimes conversion disorder is precipitated by psychological stress. People who respond to a trauma by becoming literally paralyzed because they feel powerless. They don't control it. They think, this is not something that they intentionally do. They're not pretending to get attention. It is a conversion disorder. They have converted their psychological pain into a physical symptom. And we have, sometimes a psychological factor will affect a medical condition. And you have a general medical condition, but it came about because of psychosocial factors. Factitious disorder is something I want you to be aware of. Those of you who work in the emergency room or who work in doctor's offices may experience this. It's uncommon. It's, according to your textbook, 0.8 to 1% of the psychiatric population, which is a subset of the general population. So a very small number of people will acquire what's called, or will have what's called factitious disorder. And factitious disorder is a conscious pretending to be sick, and they will do bizarre things to their bodies to distort their lab values or to force the surgeon to give them surgery. The individual is pretending to be ill in order to receive some sort of emotional support. This is a secondary gain. We can get primary gains from some things. For example, when we come up with a bad headache and we're throwing up, we get to stay home from work. That can be a primary gain. And so somebody with somatic symptom disorder might get primary gain from their symptoms. Somebody with factitious disorder, their primary gain is that attention that they get when they are sick. And it can go to some pretty bizarre extremes. One of the worst manifestations of factitious disorder is what's called factitious disorder by proxy. You also knew it as Munchausen syndrome by proxy. And this is where somebody will designate someone else to become the patient while they become the caregiver. And they play this role very dramatically and they want to receive attention. Oh, I don't know how I can bear it. And typically the presentation is a mother with a child, and they have done something to give this child symptoms that necessitate medical treatment. And this can be a really dangerous situation for the child. There were case reports of mothers who maybe poisoned their children with something to make them sick. They gave them too much salt, for example, and that gave them a hypernatremia, and it looked like a kidney disorder, and it became a big drama that they were enmeshed in. And this really is a type of child abuse. So those are your somatoform disorders, and that really is as much as you need to know. If you want to know more, you can really dig into your Townsend text, but I think that's enough. We're going to cover dissociative disorders relatively quickly. They're very rare. You're unlikely to see them in practice. You may, so we'll cover them very briefly. Dissociative amnesia is defined as an inability to recall important information. And you can't explain it by ordinary forgetfulness. It's too extensive for that. It's not, I can't remember where I put my car keys would not fall under this category. And it cannot be explained by the effects of substance abuse or a medical condition. So for example, if you black out with alcohol, it doesn't count. It's not explained by a seizure or by any other medical condition that you might have. Okay, so that is what dissociative amnesia entails. It usually follows a severe psychological stressor, and it can be categorized as the following 4 types. There is localized amnesia, which is the inability to recall incidents associated with a traumatic event for a specific period surrounding that event. So, for example, if I'm in a car accident and where I'm severely injured, I might say, I don't remember anything after the light turned green. Maybe I don't remember being hit by somebody who ran a red light. I don't remember the impact of the collision. I don't remember the windshield glass breaking. I don't remember the EMTs pulling me out of the car. I don't remember being in the hospital, even though I was awake, alert, and talking to people during those events.
That is a localized amnesia. It is global. You don't remember anything for that period of time. Selective amnesia is a person who can recall only certain incidents associated with a traumatic event for a specific period following that event. And this very often happens when people are in severe anxiety or panic mode. So let's say that I am the victim of a violent crime. Somebody robs me at gunpoint. I can remember some details of that crime, but I can't remember all of it. I maybe remembered, what jacket he was wearing, but not how tall or what he said. Maybe I'll say all I remember is this. And the unfortunate thing is that when people get to that level of anxiety and their perceptual processing ability decreases so much, and they are victims of violent crime, they very often cannot be effective witnesses against that perpetrator. And so this is sort of something that people who work with victims of violent crime, and particularly in sexual assault, will work with these individuals to try and retain as much of that recall as possible. It's not always something that can happen. Generalized amnesia is very, very rare, and this is like what you're used to seeing maybe on TV, if you've ever seen those shows, even in cartoons. Where am I? Who am I? And they remember nothing that has ever happened to them during their entire lifetime, including their personal identity. Very, very rare. Occasionally it happens. A fugue state is a subtype of amnesia where there is sudden, unexpected travel, and that person can't remember who they are, or some of their past, or all of their past. And that's a fugue state. Very, very rare. Again, you might see it. Somebody walks into the emergency room as a Jane Doe, and they have a life somewhere else. But these are states that can't be explained by any of the dementias, by the way, also. So if you have an elderly individual and they have memory loss, and it's a more organic memory loss, that's not considered dissociative amnesia. Just so you have a frame of reference for that. Dissociative identity disorder used to be called multiple personality disorder. Very, very rare. You'll probably never see it. Of all the mental illnesses I've seen, not a single one. It's more something you're going to see in the literature. If you work in psych and you see one case in a lifetime, you can probably write a book about it or make a movie. Dissociative identity disorder involves a rapid personality switch. These are distinct personalities. Sometimes they have whole stories for who they are. These people can actually function at a reasonable level. Some of them have advanced educational levels. Many of them hold jobs, but it is considered a coping mechanism for stress. And lastly, we have depersonalization and derealization disorder. Most people have episodes of depersonalization, derealization following stressful events. It's usually not enough to qualify for a diagnosis unless it really interferes with functioning. But it's sort of a transient change in the way that you are self-aware. You may have feelings of unreality, like this is so bizarre, it just can't be happening. Changes in your body image, time distortion, very, very common. Feelings of detachment from the environment. You know that you should be having emotional response to what's going on, but you're just very numb and detached. Some people will report a sense of observing themselves from outside their body. That would be sort of more unusual in my experience. But it's really a disturbance in your self-perception and in the perception of the external environment. And usually people who are experiencing depersonalization have anxiety, depression, they think they're going crazy. They may have physical complaints, they may have obsessive intrusive thoughts, and really that time disturbance is very common with that. So that concludes our discussion of the anxiety-related disorders, and we'll see you in class. So now that we know what anxiety and anxiety-related disorders look like and what might cause them, let's talk about what the nurse can do to help a person who has them. And there are a number of things, but we start with the nursing process always with assessment. And your book talks about a few of the quantitative rating scales. They aren't exactly objective assessment tools because they do rely a lot on self-report. However, they do help us sort of gauge the level of discomfort that person's in and the level of impairment of functioning that accompanies these anxiety disorders. So we have the Beck Anxiety Inventory is a very popular one, the Zung Self-Rated Anxiety Scale, and the Hamilton Anxiety Rating Scale. And these are mentioned in your book. In particular, they focus on that Hamilton Anxiety Rating Scale, so we'll play with that a little bit in class. But most of our information on anxiety disorders, particularly if you don't work in the psych setting, is going to be really derived from what you get talking to a person. So what we want to know is how this looks from the client's perspective. What are they experiencing? So this is subjective data that we're getting, and we want to know what's happening to you when this happens. Why did you come seeking help? If they're in a setting for some other reason, for example, they're in the hospital setting, we want to know, well, what are you feeling right now? So the patient may report that they have obsessions and compulsions. They may report that they have palpitations. They may report that they get nervous and they want to avoid certain activities, or that they're deathly afraid of needles and now you're in the hospital trying to start an IV. And this, of course, in that instance is going to be very quick conversation. But you want to know what they're experiencing in their own words, and you're going to document it as often as possible in quotation marks in their own words. You want to know onset and duration. How long have you had this? When did it start? When did you first start experiencing these symptoms? And you'll find with some of the more chronic disorders that they sort of go through periods of exacerbation and remission. And you might find that people have been living with this for years and never sought help, that they were obsessive compulsive for many years and were too afraid or ashamed to go for help. And so that gives you some valuable information. You want to know any past medical and psychiatric history. Are they maybe experiencing a condition that mimics the symptoms of anxiety, cardiac disorders, respiratory disorders? When people are short of breath, the first sign, the brain will sort of send out a distress signal, and that very often presents as anxiety or panic. You want to know if they have any previous psychiatric history. Many disorders in mental health are comorbid with other disorders, and so it's important to get that information. Now, in the instance of post-traumatic stress disorder or acute stress disorder, and even in adjustment disorder, you want to know what's going on in their lives, a history of traumatic event. Now, if they have generalized anxiety disorder or panic, there may not be any traumatic event associated prior to the onset of symptoms. There may be, or it may be more of a general, I was under a lot of stress, there were many things going on. But if there is a traumatic event, say that they were in a natural disaster or that they witnessed a violent crime, you want to know what that traumatic event entailed. You want to know the impact symptoms have on function, and this is true of every area of nursing. When a person comes in and they've got symptoms, whether they're orthopedic, cardiac, whatever, how does this affect your life? Because that gives you a really good idea of how serious this problem is to them. Does it interfere with sleep? Does it interfere with work? Are you having troubles eating because you're always nauseous all the time? Or, are you having trouble doing anything that you normally do? Socializing with others, driving your car, getting ready for work. Does it take you 45 minutes to get from your car to the front door of your office because you have to touch things along the way? Or does it take you a half an hour to undo your makeup and redo your makeup and undo your makeup and redo your makeup because you have a body dysmorphic disorder? So that's important information. That tells you probably more about the disorder than anything else. How is this impacting you and your life? How is it impacting your relationships? You also want to know medication or substance use, and we've already talked about this. People who are drinking like Red Bull all day long, people who have caffeine addictions to coffee, diet cola, regular cola, green tea, anything that contains caffeine can have symptoms of anxiety. They're stimulating themselves. If they have ADHD and they're on a stimulant medication, that can precipitate anxiety. If they have thyroid disorders, if they have cardiac disorders, if they have hypoglycemia, it's going to look like anxiety. It's your body's way. They put out a fight or flight response. You get this surge of adrenaline. Some adrenal tumors can look like anxiety. So you want to get a thorough medical history. And with that, the physician will usually order some kind of workup to make sure that there's no physical cause for these symptoms. We want to know about their substance use, obviously. If they are abusing nicotine, if they're abusing cocaine, amphetamines, methamphetamines, these medications have a definite impact on anxiety. And we want to know what they're doing to self-medicate as well. So people who have a lot of anxiety, maybe using, or post-traumatic stress disorder, as we talked about, maybe using alcohol, maybe using opiates, maybe using benzodiazepines inappropriately in an attempt to resolve their symptoms. We want to know if they have any symptoms of depression or mood disorder, because depression and anxiety tend to run hand in hand. Part of the reason for that could be that the serotonin, norepinephrine, and GABA imbalance has similar features in both diseases. You see decreases of serotonin and norepinephrine in both disorders, and imbalances of the GABA neurotransmitter. And so it's important to assess, are they also depressed? There's also cognitive factors. People who do a lot of negative self-talk end up depressed and anxious because they feel like failures, and then they're anxious about the anticipation of failing again. So we want to know what's going on there. Obviously, if they have post-traumatic stress disorder, they're also sitting ducks for depression, and then we want to assess suicide risk. Post-traumatic stress disorder, most of the anxiety-related disorders really run along more of we don't use the term neurosis as much, but non-psychotic spectrum. When you get into post-traumatic stress disorder, it can really run the gamut. These people can look very psychotic because they're having flashbacks, they're depersonalized. So we want to know if there's any other symptoms of other depression, mood disorder concurrently with this disorder. And we want to know what's going on in their lives that precipitates symptoms. Now, in your generalized anxiety disorder and your panic disorder, there might not be any one stressor that impacts it. In OCD, there might not be any one stressor. Well, when this happens, I do that. Instead, what you find is that as the overall stress level increases, the behaviors and the symptoms increase as well. So a person with generalized anxiety disorder who now has a lot of deadlines to meet, or is having financial difficulties or marital difficulties, will have an increase in symptoms. A person with OCD will have an increase in both obsessions and compulsions, and those compulsions can get very noticeable. And it's important for the patient and their family to understand that, and we'll talk about that more with interventions. But we do want to know what's going on in that person's life. It might not be the first thing. It sort of depends on how they present. But if they're having social anxiety disorder, we want to know, what are the events that precipitate your symptoms? What happens when this happens? And how does this impact your life? And we want to get their family input, particularly when the patient is a child, or when relationships are impacted by the behaviors. So we might want to get as much family input as we can. And that is our interview. Now, objective findings. When we assess the physical signs of anxiety, what will the nurse see? If you get a test question on ATI or wherever that asks what signs of anxiety, or you might say symptoms, even though we know signs are objective, would the nurse see? These are objective data. Changes in your vital signs. A person might have increased heart rate or blood pressure. They might be breathing rapidly and shallowly. So we're going to look for changes in their vital signs. Always get vital signs. It never hurts anybody. Diaphoresis or sweating. Or we might get pallor. We might get flushing. We get those vasoactive changes. They might have vasoconstriction that leads to pallor. Or they might get like a hot flash, like flushing. People get flushed when they're under stress. You might see somebody who has trembling or shaking that extends to their vocal quality, so they might have an unsteady voice. They might sigh a lot. Again, the tachypnea, rapid, shallow breathing. Increased muscle tension. These are people who sit on the end of their seats. They've got clenched fists. Their faces look tense. Increased swallowing or throat clearing, very typical of anxiety. And then you'll see restless behaviors. And this is something I want to point out and maybe slow down a little bit. Particularly when you are in the psych setting, a patient who is prone to aggression, who starts to exhibit restless behaviors, and by this I'm talking about pacing, rapid speech, excessive speech, nervous laugh, increased loudness, or the vocal tone keeps going up and up and up. When you start seeing that, that's a sign of increased anxiety. When a patient who is also maybe psychotic or paranoid or aggressive in some way gets increased anxiety, they will start to exhibit this behavior. I know you've already had schizophrenic disorders. I know we've already spoken to you guys about what happens on clinical. But really, really pay attention to what your patient is doing. When you see that increased motor activity in a patient who could become aggressive, you need to de-escalate. You need to back off. For you as a novice student, you're not going to use any de-escalation techniques. Don't get fancy. You're going to say, I'm sorry, I think my instructor needs me for something. It's X o'clock and I was supposed to be somewhere 10 minutes ago. Excuse yourself from the situation. And when you start seeing these behaviors, make sure that you are not somewhere where you might be cornered. Make sure that you have a pathway to an exit. And I'm only saying this to help keep you safe. But these are the restless behaviors, that are associated with anxiety. And so when you see a patient who has increased anxiety to the point where their motor activity is escalating, and it seems to be sort of exponentially spinning out of control, you need to excuse yourself. But in a normal person who just has garden variety, generalized anxiety disorder, or maybe panic disorder, this might take the appearance of tapping or fidgeting or, sort of a little bit of extra movement, but certainly not to the point where you would see somebody walking back and forth and getting louder and faster. Those are restless behaviors you might see, and you would document them. Worried facial expression. We all know what worry looks like, that furrowed brow, that strained expression. If somebody appears with a worried facial expression, you would document it that way. When people cannot focus on a conversation, people, as their anxiety grows, we've already talked about the levels of anxiety. A little mild anxiety makes you more likely to listen and pay attention and learn. Moderate to severe to panic level anxiety runs a spectrum where you will see that person less and less able to concentrate. And that's why when we talk about the dissociative disorders and you talk about selective amnesia, very often when there's been a very stressful event, an accident or a crime or a natural disaster, you'll see people have very selective memory because their attention, their selective attention was not where it should have been. Their anxiety was too high. Okay, so there's that inability to focus on the conversation. People who startle easily, every time the door opens or they hear something, they startle. That is a sign of anxiety. That's that increased alertness or awareness. So that would be something that we would note. Repetitive or ritualistic behaviors. These tend to be very obvious. People pick at their skin. People have to touch things. It's very weird, ritualistic, stylized behavior. And this would be something you would observe. Like I said, people who take 45 minutes to get from the waiting room to the therapy area or the intake area because they have to stop and touch things in certain orders. Those behaviors we would want to acknowledge and document. Hair pulling and trichotillomania. If you see hair pulling, you would certainly document it. Nail biting is another manifestation. I mean, there's all those little things. And tics. Tics are little transient, involuntary movements. So that is how we would assess people with anxiety disorders. So now that we're done with the assessment piece, we're going to go to the next part, which again is nursing diagnosis. I'm going to refer you guys to page 895, Appendix F in your textbook. I actually had this printed out, and believe me, if I thought to kill a tree, granola crunching hippie that I am, it's something that will help you, particularly on your process recordings where you are asked to come up with 3 nursing diagnoses to fit your client. Okay, and this is very helpful because what it does is it takes client behaviors and connects them to a nursing diagnosis. What this chart does not do is discuss the related to and as evidenced by factors. So let's practice a little bit. Let's say that we have a patient who has anxious behavior. And so our nursing diagnosis is going to be anxiety. Let's get that in a different color. Now we need a related to. And our related to factor could be anything that we think is causing this behavior. So how about anxiety related to, let's say perceived threat, to self-concept. Person has a lot of negative self-talk, and we've decided that that's what's causing their anxiety. And then we're going to have our as evidenced by. As evidenced by muscle rigidity, nausea, increased heart rate. So that'll be our nursing diagnosis for that patient. And let's say that we have somebody with repetitive behaviors. So let's go to page 896. We have ritualistic behaviors, and we're going to come up with anxiety or ineffective coping. So let's try ineffective coping. Ineffective coping. And obviously, if they're counting everything or touching everything or washing their hands 85 times, this is an ineffective response to a perceived threat. So we're going to have ineffective coping related to perceived threat to physical integrity or physiological integrity. The person is afraid of germs and they keep washing their hands. So, as evidenced by would be repetitive hand washing. Okay, so that's a diagnosis for OCD. Now let's go on and we'll make another diagnosis for, say, phobia. So we can come up with fear, if you look on your chart on page 896. Fear related to, and we're going to do our phobic stimulus. So exposure to dogs as evidenced by panic symptoms when exposed to dogs. So that would be how we work in nursing diagnosis. So let's get rid of some of these now that we've practiced with them. And we're going to list some of the ones that are more common to our anxiety-related disorders. So here is a bigger, although not exhaustive list of nursing diagnoses that apply to the anxiety-related disorders. Now I want you to remember that a nursing diagnosis is not the same as a medical diagnosis. When we make a nursing diagnosis, for example, of anxiety, we are identifying a mental or behavioral state that is related to something a nurse can address, and it's evidenced by something a nurse has assessed in that patient. And so when we diagnose anxiety, we are not diagnosing anxiety disorder, we are not diagnosing panic disorder, we are diagnosing a mental state that we have observed. So we can have anxiety related to unconscious conflict, we can have anxiety related to exposure to stimulus or anticipation of exposure to stimulus, but anxiety is that mental state. There's panic anxiety. So anxiety is the main diagnosis, but we can qualify it with either panic or severe anxiety so that it's a little more descriptive of what that patient is experiencing. Powerlessness, very applicable to a lot of people with anxiety disorders. They don't feel that they're able to control them. If they had the coping mechanisms to control their anxiety, they wouldn't be coming to you, and it wouldn't be a problem that you would be able to address, as they would be effectively coping. Fear, very often when we look at phobias, we are looking at a cognitive appraisal of a stimulus. It might be distorted, but it is a fear related to that stimulus or exposure to that stimulus. And so that is an applicable nursing diagnosis. Social isolation can be very important for the patient with agoraphobia or social anxiety disorder. Patients who, because of their symptoms, have isolated themselves socially. Ineffective coping is another very significant nursing diagnosis for people with anxiety-related disorders. Anxiety is a very uncomfortable feeling, and some people will cope with it effectively, some people won't. If they could cope with it effectively, chances are it would not be coming to your attention. So that's a pretty good diagnosis to use for people with anxiety. Ineffective role performance. When the disorder interferes with the person's functioning at work, in relationships, in other aspects of their life where they're expected to perform a given role, we have ineffective role performance. Disturbed body image for people with body dysmorphic disorder. Those imagined defects or flaws in their appearance or function. It could be related to any number of things. Distorted thinking would be my related to factor, as evidenced by, whatever behavior they're exhibiting. Ineffective impulse control is an important diagnosis for people with OCD or obsessive compulsive disorder. Remember that those compulsions represent impulses that they cannot logically talk themselves out of. They may have those unwanted images and they can't rationalize them. So that is ineffective impulse control. Post-trauma syndrome, that is a very good category for your acute stress disorders and your post-traumatic stress disorders. You can have complicated grieving for the patient who, this also goes with depression, but if the grieving is complicated by
panic attacks or acute stress disorder or adjustment disorder. That person is not following a normal path to resolving their grief. We can use that diagnosis. Risk-prone health behavior, these people who self-medicate, people who have disordered eating, people who engage in any type of risky behavior because it alleviates their anxiety. So those are some good nursing diagnoses. Remember that when you have a nursing diagnosis on your process recording, it must have a related to and an as evidenced by. That's what makes it a nursing diagnosis. That will help you plan your care. So now that we've established our nursing diagnosis, we start to plan for our care, and we have some outcomes identification. Now try to remember that on most exams, including the NCLEX, your questions should really focus you more on assessment, planning and outcomes identification, and implementation of your plan or intervention. Very little of the NCLEX, if any, is going to be on an actual nursing diagnosis. More of it is going to be on what does this assessment finding mean, what's an appropriate goal, and what do we do about it. Some on evaluation as well, but those three areas are where you're going to focus most of your energy. So it's important to have an understanding of how you would plan appropriately for a patient with any condition, but in this case we're going to talk about anxiety. So you need short-term goals, you need long-term goals. A good short-term goal for anxiety is client will verbalize an adaptive coping method when experiencing escalating anxiety within 1 week. So they're going to verbalize, they're going to make their own plan. That's a short-term goal within a week. That maybe they will say that I'm going to use visual imagery, or I'm going to use deep breathing. That would be a short-term goal for that patient. A long-term goal for that patient might be that prior to discharge from therapy, they will effectively manage symptoms of anxiety when they're at that level 2 stage before it becomes severe or panic. That could be a long-term goal. When our nursing diagnosis focuses on other issues such as ineffective coping, obviously we are going to make our goals revolve around more effective methods of coping with stressors. When there's a body image disturbance, we're going to look at a more realistic appraisal of their appearance. So the client should verbalize understanding of or verbalize a better perception of their own body image. So you're going to sort of center your planning around where you want to end. If the behaviors that we're targeting are related to OCD, obviously you're going to see a decrease in ritualistic or repetitive behaviors. So that would be how you would set goals for the patient with anxiety-related disorders. Okay, so we're ready to talk about some nursing interventions. Now that we have our goals set, if you have a patient experiencing panic anxiety, and that's your primary nursing diagnosis, this is a crisis situation, and so there are certain things you're going to do. You never leave the patient who's experiencing that acute panic. That is terrifying to them. So stay with them and maintain, or arrange for someone to stay with them. Maintain a calm, matter-of-fact approach. Anxiety can be contagious, and people who are panicky can make us all a little bit anxious. So you can't reflect that to the patient. You can't mirror that, a mental state. You have to maintain calm, matter-of-fact approach, short, simple sentences. You cannot get in a long conversation with these people. Remember that their perceptions and their ability to focus are severely limited. So very short, simple sentences. You might have to really direct that person, direct the patient to breathe slowly and deeply. Sometimes you have patients who are in a lot of pain and it causes that panic level anxiety too, so this works for that. So you say, slow your breathing down. You might have to say, breathe with me, in, out, just like you would with a labor patient. You just kind of have to direct them to breathe because they really have a limited ability to follow directions. So your directions to them have to be very, very short and simple. Low levels of stimulation. If you can get the lights low, I mean, you can't always do that in the medical setting because you have to be able to see to assess what you're looking at. And obviously, if you've got a patient who's come in with a trauma and they're in a panic state, you can't turn the lights down. You have to assess the damage. So as much as you can reduce the noise and the lights and the external stimulation, you should. If that's not possible, work with what you have. After this immediate episode is passed, you really have to wait until it's de-escalated a little bit. You can allow the patient to express their feelings and support them as they explore the possible reasons for why that happened. And you definitely want to educate the patient if it's a simple panic attack on the signs and symptoms, especially if it's a panic disorder, worsening anxiety, and teach them some techniques to sort of intervene in that cascade. Now, collaborative interventions. If you have somebody who's experiencing a panic attack, your nursing interventions are going to be, what we've just said, but it's probably not going to go far enough. You may have to administer anxiolytic medication, and for this, you're probably looking at a benzodiazepine. For a long-term solution, benzodiazepines are less than ideal. They do create dependence and addiction issues. But for a short-term intervention, you might have to administer some Valium or some Ativan. That might be the only way that you can get this patient back into a place where they can then be redirected. Panic can really run away with itself. So those are some things that you want to keep in mind for that. Okay, so we can talk about some interventions that we use for other disorders. For example, OCD. This is ineffective coping. They have these ritualistic behaviors that they use to cope with their anxiety caused by their obsession. So some of the things that the nurse will do, obviously therapeutic communication is the very first thing that you would do. You would explore with that patient in a non-judgmental way what their obsessions are, what they're feeling when they have those obsessions, and then what their compulsions are and the connection between the two. Talk to them about how, or get them to explore how that might be an ineffective coping mechanism. And then we can use techniques. Your book mentions one called thought stopping, and there's more about that in chapter 14 if you're really interested. But thought stopping is basically once they have that thought, that uncontrollable impulse or that image, they say to themselves, stop. They can say it out loud in the beginning, and then they internalize the stop, and that interrupts that thought pattern as it's beginning. You don't want to wait until they have a severe anxiety over their skin is crawling with germs, they need to wash their hands. As soon as they feel like my skin feels like it's crawling, that very first time that they think that, they need to think stop. They can use different types of interrupters. There can be code words or safe words, but that is one way that you might deal with OCD. That's a nursing intervention. Now, when we're dealing with post-traumatic stress disorder or acute stress disorder that is caused by a trauma that's outside the normal range of experience, we want to try maybe some different tactics, and a lot of that will deal with support groups. Finding a recovery environment that is therapeutic for this person. We're going to use our therapeutic communication techniques with all of the anxiety-related disorders. That's probably the most important intervention that we have. But finding community supports for folks that have post-traumatic stress disorder can be very important, especially combat veterans need to find people who have been in that situation. Victims of violent crime can be referred to support groups for that. That is a major predictor in successful recovery from PTSD and acute stress disorder as well. So, and then we want to obviously assess for any kind of maladaptive coping behaviors like alcoholism or substance abuse and address those separately as part of our care plan. And lastly, for any of these disorders, we want the families to be involved in the plan of care, so we want to educate the families on what these disorders are. We want to generate empathy for the patient so that they understand that their participation in the patient's recovery is important. People, for example, who have post-traumatic stress disorder may need a separate support group that addresses their needs, and so that they become a more therapeutic presence in that person's life. And you may need to also educate the family that you might see an increase in these behaviors when there's an increase in stress. So when you see, for example, that you have a child and they're pulling their hair more frequently, you may need to assess what's going on, what kind of stressors are in the home or in the school environment, and sort of intervene for that. So educating the family is also an important nursing intervention. And evaluation of outcomes, we don't need to spend a lot of time on. Obviously, anytime you're evaluating the outcome of your care, you're looking at your basic goals and saying whether or not this person made progress towards those. And if your intervention is effective, you are going to see a reduction in the problematic behavior and in the self-reported level of anxiety. And so that is how we use the nursing process to help people with anxiety-related disorders. Okay, so now that we've explored the nursing process,
in relation to anxiety disorders and anxiety-related disorders, we can start to talk about things that the interdisciplinary team can implement. For example, we have the different therapies, and then we have psychopharmacology. There are also some complementary and alternative strategies that we can bring in, and I'll talk about them as well. So we have individual psychotherapy, where the client will sit with a psychotherapist, somebody who is trained especially in the techniques of psychotherapy, usually at the master's level or beyond, and explore their issues and look at ways to cope more effectively with their anxiety. And that is useful in conjunction with other strategies very often. Sometimes it's the only strategy people need. We have cognitive therapy and behavior therapy. I'm mentioning them together because very often you'll see them in combination as CBT or cognitive behavior therapy. Cognitive therapy addresses the distorted thinking that a person can have that predisposes them to an anxious reaction to stressors. And behavior therapy interrupts those automatic responses that people have to stress. For example, if your automatic response to stress is hair pulling, there are behavior therapies that aim to reduce that. So that's cognitive and behavior therapy. Family therapy is very important in the anxiety-related disorders, particularly the more severe manifestations of anxiety, OCD, post-traumatic stress. Family therapy sort of takes the position that not one individual is sick, the whole system becomes sickened, whether it's cause or effect. Either the person is in a dysfunctional family situation, or the family becomes dysfunctional because one of their members is mentally ill. But what family therapy will do is it will address all members of this family system and make the family a more therapeutic milieu, a better recovery venue for this person. And so each member's role in the illness and each member's response to the illness is going to be explored. And there's going to be a lot of education that goes on between family members. Hopefully we'll have better overall family functioning, which will support the individual who is identified as the person with the diagnosis. Group therapy, very, very important, particularly in your post-traumatic stress disorders. As I mentioned with post-traumatic stress, one of the problems with it is that that person might be in a recovery setting where no one else has experienced what it is that they have. And it is something outside the realm of normal human experience, and so there are very few people that person can go to. Group therapy can be very effective for this disorder because it puts people in contact with other people who have experienced similar trauma. And so if you have, for example, a support group that's aimed towards victims of violent crime or survivors of suicide, SOS, or for people who have combat-related PTSD, when you have people who have similar experiences, the loneliness and isolation tends to go away, and there can be a better problem-solving approach. Sometimes you'll find that one member of the group articulates a feeling or behavior in a way that another person can relate to, or somebody has found a way to cope with their stressors a little bit better. And so group therapy in that situation can be very, very helpful. And then we have some of the specialized techniques. We mentioned for phobias, flooding or implosion therapy, which is like a massive exposure to that stimulus. Again, this is not something that you're going to attempt to do as a novice student nurse. This is something that a trained therapist would implement. And it's similar to, like I said, you're afraid of bees, you have a deathly fear of them. That's taking this person over to a place where there's a beekeeper and exposing them to a hive all at once in a way that's safe, where they're not going to be harmed, and so that you can convince them that their irrational, excessive fears are untrue and that they can survive what it is they're afraid of. Again, has to be done by a trained therapist. Systematic desensitization, we already sort of talked about. This is that staging of exposure to the phobic stimulus. Thought stopping. Thought stopping is very good in types of anxiety where people ruminate, particularly your obsessive compulsive disorders. When the person starts to experience that obsession or that negative thought, what they do is they say stop, or maybe they have a safe word or code word where they interrupt that thought before it takes off and runs away with itself. And so initially you start by maybe saying it out loud. Eventually it has to be something you say internally, because you can't be sitting in the middle of the mall and going stop to no one in particular. So that is another technique that a trained therapist can employ. And it's a pretty simple one. And it's really a behavior therapy. It sort of interrupts that automatic condition response. Habit reversal therapy, very useful for things like hair pulling, nail biting, any kind of like a lot of the compulsive behaviors. The person first needs to be made aware that they're doing it, that they're pulling their hair, let's say, and then they need to interrupt that, and they maybe need to replace that response with something that is not harmful to them or does not include that habit. So it's habit reversal therapy. Prolonged exposure therapy. This is something that is used in post-traumatic stress disorder. It's very similar to flooding or implosion therapy, and it involves reliving that experience in a safe place, maybe re-experiencing it to an extent mentally or with visual imagery. Sometimes hypnosis is employed, and having that person sort of reprocess it in a way that doesn't provoke such extreme anxiety. Then your book mentions something that I had never heard of called eye movement desensitization and reprocessing, which involves rapid eye movements during exposure to the memory or the stimulus. For example, if somebody was in combat, talking about the combat while teaching them to have rapid eye movements, and it sort of helps them detach from that scenario and depersonalize it a little bit. Crisis intervention is a specialized technique. I'm sure you heard of it when we talked more about the therapeutic milieu. And this is a short-term problem-solving approach when a person is in a crisis state. For example, they're in panic disorder. Once you kind of get them calmed down, you deal with the crisis and teach them to deal a little bit better. But it is very short-term and it requires follow-up. So those are some of the treatment modalities that don't involve medication. In addition to those therapies, we have some pharmacological agents that are useful in the treatment of anxiety disorder. Some of them are better for short-term use. They rapidly decrease symptoms. Some of them are better for long-term use. They help the patient function more effectively. So we have antihistamines. I know those of you who were in fundamentals last year with Mrs. Roberts learned that we sometimes use some of the antihistamines preoperatively to decrease anxiety prior to a procedure. And one of those is hydroxyzine. Very commonly used. It's also known as Vistaril or Atarax. It does potentiate narcotics. And sometimes Benadryl is used, particularly Mr. Davis tells a story of a patient who was about 8 weeks pregnant and not willing to terminate. The only medication they could really give her was Benadryl to reduce the anxiety that made her symptoms more troublesome. Not sure how effective that was, but for people who have less severe anxiety, that might work. Benzodiazepines are probably the biggest class you're going to need to know about, and when you're taking your NCLEX, they will ask questions about benzodiazepines. I know ATI is heavy on the benzodiazepines, so these are members of the PAM family. Not every one of them has the same last name. Some oddball cousins like alprazolam or Librium, which is chlordiazepoxide, they don't have that PAM suffix, but most of them do. We have diazepam, lorazepam, oxazepam, clonazepam, which is Klonopin, and these are medications that work very rapidly to decrease the symptoms of anxiety. They are used for generalized anxiety disorder and panic disorder in an acute episode. The problem with benzodiazepines comes when people become dependent on them. They are habit forming, they are physically and psychologically addictive. You cannot abruptly withdraw people from these medications. They will experience physical withdrawal symptoms. They need to be tapered gradually. The other big problem with benzodiazepines, they mimic the action, particularly when the dose is larger or when the patient has decreased ability to metabolize the medication. It will look like drunkenness. These people might have slurred speech. They will have decreased reflex, decreased reaction time. Their reflexes are a little less sharp, and they'll have an unsteady gait. In particular, remember that elderly adults are susceptible to benzodiazepines and that they become a falls risk when they are on inappropriate doses. But people with dementia very often are managed on benzodiazepines because they get that anxiety that they can't manage effectively, and teaching them strategies doesn't really work very effectively with the cognitive impairment. And so you'll see them on smaller doses. Usually you'll see them on like a half a tab of Xanax. Ativan's a better one for them. The adverse effects you get, obviously sedation, decreased cognitive function. These are people who should not be driving a car or engaged in heavy machinery. You can get some anterograde amnesia. Sorry if I said that wrong. That means that after they take the medication, they can't remember what happened. It's like a blackout that you would get with alcohol. People can get toxicity. And if that happens, IV toxicity is more common than oral toxicity. It's very hard to overdose on oral benzodiazepines, but it can happen with IV use. Like Valium comes in an IV form, diazepam or lorazepam, Ativan comes in IV form. And so there is an antidote for that. It's called flumazenil. You probably remember it from your pharm class if if you're one of the people that just took pharm. I know it was in your PowerPoint. The trade name for that is romazicon. And that counteracts sedation and it reverses the adverse effects. And obviously, if you think somebody is toxic from benzodiazepine, you want to monitor their airway and their cardiovascular status and provide some fluids. Some people will get a paradoxical response from benzodiazepines. Instead of becoming calmer, they'll get more excited or more anxious. They may have some insomnia. Not common, but it can happen. With short-term use, you usually don't see too much withdrawal symptoms, but people who are on long-term use should be aware that they may have withdrawal. And when you're assessing a patient with anxiety, you want to make sure that you know what that patient's been taking, how often. Maybe they had a PRN order that was only meant to be given in, once in a while when that person's anxiety was unmanageable, and they're taking it 3 times a day. So that is something that you'll want to assess. Next on the list, you'll notice that we have buspirone, also known as Buspar. This is an atypical anxiolytic. Anxiolytic means it stops anxiety. Anything that's lysis or lytic, it kills something. So an anxiolytic stops anxiety. It's not a barbiturate. It's not sedating. So Buspar is very useful in the long-term treatment of anxiety disorder. The problem with buspirone is that it takes time to accumulate to a therapeutic level in the patient's blood. Now, your textbook says at least 10 to 14 days. ATI materials are telling me at least 3 to 6 weeks. So you probably start to see an initial response in a couple of weeks and maybe a peak or a therapeutic level by 6 weeks. It can be hard for a person to wait, and that's where maybe the benzodiazepines are a little bit more useful. But buspirone is very good at combating the symptoms of anxiety. It just takes time to work. It is not sedating. They can work. They can operate machinery. They can drive. It's fine. It's used for panic disorder of the long-term variety, generalized anxiety disorder. It can be used for OCD. It can be used for social anxiety, and it can be used for post-traumatic stress. So it is a very useful medication. The big side effect is really more your GI stuff. You can have nausea. So you want to take it with food. And it does interact with other medications, in particular erythromycin, St. John's wort, which is like a alternative therapy for depression, and grapefruit juice, because it works on that enzyme in the liver. So you want to tell the person to let their doctor know that they're taking buspirone, all their doctors, and to avoid herbal preparations that have St. John's wort and don't drink grapefruit juice, and that's Buspar. SSRIs, another class of medication used in long-term treatment, they are actually an antidepressant. They are selective serotonin reuptake inhibitors. They increase the availability of a neurotransmitter called serotonin at the synapses, which is where the person needs it to decrease symptoms of depression and anxiety. And remember, when we talked about assessment of the patient with anxiety disorder, we want to know, are they feeling depressed, are they feeling down? Because an imbalance of these hormones, serotonin, norepinephrine, and that GABA, are very often common to both disorders. And so a person who has comorbid depression really will benefit from an SSRI. SSRIs include like sertraline, which is Zoloft, Prozac, which is also fluoxetine, paroxetine is Paxil, and these are used in many of the different anxiety-related disorders. Now, it does take a little while to work. Sometimes it can take up to 2 to 3 weeks. It can take up to 4 weeks for an SSRI to build up. Some people will start to feel the effects almost immediately, but they should be instructed that it could take a little while. And in the first few days or weeks, they may have some side effects. Headache is very common. They might have some nausea. They might get drowsy very easily. So if they're having adverse effects, they need to let their provider know before they stop taking it. Most of the times that's a transient phenomenon. They should be aware that this can happen. particularly the drowsiness. They might not want to drive until they know how the medication affects them. Later on, when the person's been on it for a long time, maybe say 5-6 weeks, you get two very troublesome side effects that may make people non-compliant with therapy. And the first of which is weight gain. People can gain up to 20 pounds in the first 6 months on an SSRI. And for obvious reasons, this is distressing to the patient. They can also get some sexual dysfunction, again, a very troublesome adverse effect. What they need to do is talk to their provider and keep that conversation open. It may be that a decreased dose causes fewer side effects, or it may be that they need to switch to a different SSRI or a different type of medication altogether. But SSRIs are very useful in the treatment of anxiety as well as depression. They have application in generalized anxiety disorder, panic disorder, OCD. In particular, I remember a patient who was on a high dose of Luvox or fluvoxamine. Social anxiety disorder, we talked about paroxetine or Paxil. Trauma, any of your PTSD or your acute stress disorders or your adjustment disorders can be very useful. So those are some indications. People can withdraw from these. So after a long period of use, they need to taper the medication. In terms of the other antidepressants that are used for anxiety-related disorders, there is a heterocyclic antidepressant. I don't want you to memorize this. Don't even bother writing it down. But it's called Wellbutrin or bupropion. You'll learn more about it when you study depression. It's also used for other disorders like ADHD. So it's not the last time you'll hear of it, but there's also tricyclic antidepressants such as Elavil or Nardil. Those are sometimes used for anxiety. Again, you're dealing with the serotonin or epinephrine system. SNRIs like Effexor, don't write any of this down. Don't worry about it. It's just something you should know. Beta blockers, this I do want you to know. And if you have an existing template on beta blockers, which you should, I want you to write across somewhere on that sheet that propranolol, also known as Inderal, is useful in the treatment of anxiety. So let's talk about why a beta blocker might be useful. Those of you who have had me in clinical know that I'm kind of a stickler on the different classes of antihypertensives and how they work. Well, beta blocker works by slowing impulses across the SA and AV node. It sort of mediates that fight or flight response that we get and decreases your heart rate and blood pressure. Okay, so think about this for a minute. When you're at your MAC and you are giving the medication, it asks you for the vital signs, and you have to know what the blood pressure and heart rate are. Well, what are some of the main symptoms of anxiety? You're going to get an increased blood pressure and you get increased heart rate. So if we lower those things, we decrease the symptoms related to anxiety. Also, when you are at your MAC and you're ready to give, say, labetalol or carvedilol, there's a little pop-up window that says, may mask the symptoms of hypoglycemia. Think back to diabetes and remember what I told you about that fight or flight response. Hypoglycemia feels like an adrenaline rush. It feels like, oh my God, I'm going to die. It's the brain's way of signaling that you need to act quickly or something bad is going to happen. Beta blockers mask that by sort of squashing that exaggerated response, that adrenaline response down. And so when you have a person with anxiety disorder, obviously the beta blockers will work to decrease the symptoms associated with that fight or flight response. So that's propranolol. Anticonvulsants are sometimes used. Gabapentin's the one that we can reference. And this decreases nervous impulses and chemical activity in the brain. And that's how a gabapentin type medication will work. And it's interesting, benzodiazepines are used for seizures and seizure drugs are used for anxiety. So that's basically enough pharmacology for you guys. I'd like to do a template with you in class and we'll kind of work that out when we see each other. In addition to the more traditional therapies and the pharmacological therapies, we have some complementary alternative therapies for the anxiety-related disorders. So in addition to the more traditional techniques that we just talked about, there are a number of complementary alternative therapies. A lot of them are gaining support in the literature, actual randomized controlled studies or qualitative studies even that support the use of these techniques for anxiety and anxiety-related disorders. We have relaxation exercises, and I've already kind of taught you guys how progressive relaxation, which is that tightening of one muscle group at a time, how that can work, visual imagery, Breathing exercises, we talked about these things in fundamentals. We talked about them again in labor support workshop. And exercise, particularly yoga and even cardiovascular exercise on a regular basis, are very good at relieving stress and increasing the availability of those neurotransmitters, gaining a lot of support in the literature. Meditation and prayer, especially mindfulness meditation. Really, if you're not a specialist and you haven't taken special training in mindfulness meditation, it's maybe not something that's accessible to you as a novice nurse, but it is something that you can refer a patient to. And in a therapeutic milieu, you might see group sessions on meditation, on the use of massage therapy or art therapy, music therapy. You might see those things being used. Some people have reported using acupuncture, acupressure as a way to help them manage anxiety in a long-term type sense. And there are certain dietary supplements, and these I'm going to kind of slow down and talk a little bit about, because your herbal remedies and your dietary supplements might interfere with a lot of our medical treatments. So if a patient is taking, say, St. John's wort, we need to know that, because if we're also prescribing an SSRI, we can put them into a serotonin syndrome, and we don't want that. You'll find out more about that when you cover depression and as we get through our discussion boards. But just know that certain supplements can conflict with medication. Kava is another supplement, and valerian is a supplement that people sometimes use. Passion flower, I think I've heard, and hops. These are things that people can sometimes use for anxiety. It's important for the nurse to know whether or not these patients are taking these supplements. Some of them are sedating, and the patient should know not to combine them with benzodiazepines, for example. But it is important to assess your patient's use of herbal therapy. So those are some of the complementary treatments for anxiety-related disorders.